Top Bed Talk.
Hi, thank you for joining our session. We are going to be talking about perioperative nutrition clinic and how to set it up and how to run it. I would like to introduce to you the chair of this session, Dr. John Whittle. He is an honorary associate professor of perioperative medicine at the University College of London. He works clinically as a consultant in anesthesia, critical care, and perioperative medicine at the University College Hospitals. I understand he is also almost a father of two. So welcome, John. Very good to see you. And I'll turn it over to you.
Thanks so much for having me here. I think this is going to be a good session. Perioperative nutrition prehab clinics is close to my heart currently as we're setting up our own clinic and service at the moment. So we've got a great panel for you today. So let's start with our first panel member, who is Rebecca Ilitch. She is the currently clinical nutrition manager at Northwestern Memorial Hospital in Chicago. And from what I understand, runs quite a complex sequence of nutrition services. So welcome, Rebecca. And I guess, do you want to just introduce yourself a little bit further?
Thank you, John. Yes, sure. So I'm Rebecca Ilitch. I'm the clinical nutrition manager at Northwestern Memorial Chicago. I oversee 29 dietitians currently who cover all inpatient and some outpatient areas. We have different levels of integration within our perioperative areas. So from the cardiac to spinal surgery to thoracic clinic to colorectal and to oncology, we are at different areas where either, of involvement of all of our dietitians, either a referral to an outpatient area, a referral within that clinic, and different nutrition strategies for each of these different surgeries. So very excited to be here today. Thank you.
That's excellent. So why do we need to worry about perioperative nutrition and specifically preoperative nutrition? Number
one is obviously the patient, right? Patients first at Northwestern is our motto. And we want to make sure that their nutrition is optimized so they have the best recovery time, that length of stay and that readmission. We need as many beds as we can get at the medical facility. And we want to make sure that patient is able to get out and able to be home is, our number one goal.
Across all these different specialties that you deal with, we found a need to set up specific pre-optimization clinics. And if so, how did you choose which ones to go with to start her?
We've actually been very lucky at Northwestern. Our stakeholders, being our surgeons, our physicians, have seen the capabilities of nutrition from, I think, the inpatient side, actually, of the involvement, and then flowing over to our outpatient side and really seeing some of those outcomes firsthand, which then they're reaching out to me and reaching out to our team on how can we get a dietitian to be involved in our clinic? How can we add this? So very similar to the presentation, really looking to see, what is the need? How many patients are we going to be seeing? What is that expected volume that is needed? And usually, it might be just a day in a clinic for a dietitian that might be covering a whole inpatient floor the rest of the week. So we're able to staff to it. Luckily, the clinic has been the area of supporting that cost. Small portion of the dietitian's salary is not a heavy weight for them.
So it sounds like your collaborative approach is sort of from day zero. I know that Elizabeth mentioned in the talk, and certainly in my own practice, one of our barriers has been getting early enough in the process to make a difference. How early do you feel you need to get to patients in order to make a reasonable clinical difference?
We always strive to, once we are notified of a patient, we always strive to reach out to that patient or have that intervention almost immediately. So some of our protocols are as soon as they have that screening tool, that provider is actually initiating that high protein oral supplement before we even get to that patient. So we might be able to call that patient within 24 hours or maybe 48 hours to discuss the plan. That provider that's doing that screening tool is actually the one that's saying, you are going to start on some high protein supplement until the dietitian gets to speak to you about it to optimize your nutrition. So that's how soon we really recommend to get it started right away. There's no delay.
And how do you screen your patients? What's your approach?
So we have some different areas that use different screening tools. So we have our pre-op for spinal surgery who's using a malnutrition screening tool. That will fire a recommendation to start an oral nutrition supplement and a referral to our outpatient dietitian. We also have a cardiac ERAS program that started this past year that we utilize the PONS for. So also we'll initiate an oral nutrition supplement and refer to a dietitian who will do a video call with the patient. But we have some other areas that might be looking at the BMI of a patient. Total joint, for example, might be looking at a greater than 35 BMI or an A1C level. And these would trigger the provider to also consult the outpatient dietitian that would be able to see the patient to optimize their nutrition goals prior to surgery.
So it sounds like you've got a series of different but overarchingly connected pathways. What do you see as the benefits of that approach of having different paths for different surgeries versus having one centralized service?
I think it is a way that we're able to specifically look at each patient individually and that not one size fits all approach. We're able to really optimize the nutrition for that specific surgery and the need. We're able to individualize our care plans as dietitians for these patients. I will say, though, it is a challenge to get everybody together and make sure that we're all on the same page and everybody knows what's happening at every different area. So it's a great approach, but we are looking to get into more of the pre-op anesthesia areas so that way it's more of a central approach as well.
And as you move that way, I guess you're in the US. Payment models are different in the US from Ireland, from the UK and rest of the world. Who pays and how did you go about developing business cases for these different ones and now this new pre-op program?
We definitely do diagnose malnutrition here in the US, and we have a high patient volume of patients with malnutrition. So that does help our business case. We also have utilized literature surrounding the amount of patients that the dietitian's able to see and what the benchmarks are for dietitians seeing patients in these areas. So we've utilized information on that as well. We also have developed these business cases on that particular surgery's need. And so really looking into how many patients and backtracking into how many hours that takes a dietitian. And really at the end of the day, it doesn't equate to necessarily a whole 40 hours necessarily for a dietitian in every little clinic space. So that's where we're able to work together in my clinical nutrition department and all the other clinic areas to really provide a different level of service. So it's not the entire salary of the dietitian that they're paying for, but maybe a portion of it that can be attributed by that clinic.
So at baseline, it sounds like you've got to identify and code this malnutrition diagnosis.
Mm-hmm.
That gives you the numbers that you're expecting to see, and then you can appropriately allocate your resources, it sounds like, to numbers for each service, which will make the payment a little bit easier. Is that a fair summary? Or?
Very good summary. Thank you, John.
I'm sure we'll be coming back to you with more questions. Next, I'm going to come back into London. Leah Cox, she works at King's College London, King's College Hospital. She's a cancer rehab dietitian and is involved in prehab and rehab oncology. I wonder if Leah is there.
Hi, John. So my name's Leah Cox. I work as a cancer rehabilitation dietitian at King's College Hospital and Princess Royal University Hospital, which is part of King's College Hospital NHS Foundation Trust in London. So I've been working at King's since January 2020. I've set up and now run both a pre-rehabilitation and rehabilitation service for our cancer patients across the trust. King's diagnoses over 2,000 patients per year from 23 tumour groups. The service I run encompasses 3 cancer pre-rehabilitation pathways. So the first for colorectal cancer, The second for HPV cancer, so primarily for Whipple's procedure and some total pancreatectomies. And we also run a prehab service for bone marrow transplants, so allogeneic and autologous bone marrow transplants. So alongside that, we also have a cancer rehabilitation service, which provides dietetic input, mainly for systemic treatment. This job is my first flavour of prehabilitation services and the setup and the vast service development. My previous clinical experience is around gastroenterology, surgery, intensive care and parenteral nutrition. And I've also worked as part of a peritoneal disease team as well that was providing cytoreductive surgery and heated intraperitoneal chemotherapy. That was at my previous job at University Hospitals Birmingham before I made the move to London to set up these prehab services.
Your focus is on prehabilitation, preparatory rehabilitation in the preoperative period, and often that's part of a wider optimization platform, often including exercise, maybe some psychology interventions as well. I guess from your point of view, it sounds like you have a more centralized service. Can you talk me through maybe some of the pros of that and maybe how this prehabilitation concept may differ from individual nutrition clinics?
I think the key thing really with prehabilitation is addressing, as you said, John, that multimodal element of it. So addressing the three main areas, which is nutrition, exercise, physiotherapy and psychology. It's really about addressing those three needs because we know they're so important with regards to the optimization of that patient. The service that we run at King's has been established by obviously myself as a dietitian and my colleague, the physiotherapist. And together, as well as looking at our own specialties, then we do also look into and screen for any psychological element that may hinder optimization or post-operative recovery, as well as addressing perhaps more of an organic psychological concern around anxiety, for example. I think it's also prehab highlights how you can empower a patient, from a nutrition aspect. So that may not be a specific anxiety concern, but you can certainly empower that confidence from a nutrition or an exercise element, both in the pre and post-operative stage. So the patient feels able to be autonomous in optimizing their own recovery. And I think it comes back to being that holistic health professional, not addressing just the thing that you know most about, but thinking about the other aspects that are so important in that and working them well and collaboratively with your MDT and learning from others and what they do. I think that's where I'm particularly lucky to be a rehabilitation dietitian, that you get to address all those different elements and work with some really great people as well and learn so much along the way.
So getting a prehab service up and running, one of the things that Elizabeth mentioned with regards to the POET clinics at Duke was this issue of having enough time or identifying patients early enough for nutritional optimization. Rebecca spoke to it a little bit at Northwestern. It sounds like provider, surgical and anesthesia buy-in was key. How did you approach that with your service to get there in time?
Definitely tricky. And I think we find that across the three pathways that we have, the time to surgery differs for each. For example, colorectal tends to be the shortest time frame. Bone marrow transplant is a lot longer. HPV tends to be that somewhere in the middle. The longer we have, the better. But our pathway essentially looks to catch patients within 2 working days, which can sometimes literally be 48 hours of them receiving their diagnosis, that we're able to contact them, screen, address their nutritional needs, what intervention they require, and essentially giving us as much time as possible. I know particularly within colorectal, we do aim to have at least 7 days. I know there is some good evidence that 7 days can be enough to lead to the positive outcomes that the prehab can have. But often, as I'm sure Rebecca and Elizabeth are talking about as well, sometimes it literally is a couple of days, or I've had a couple where I've phoned patients on the day of their surgery. So it's not much I can do at that point. But I think, again, it addresses what are we looking to achieve with a prehab service. It's both the optimization, but then how that links into post-operative recovery. Certainly what we do is, even if we don't catch patients with that kind of 7-day window pre-surgery, we still screen, we still identify their nutritional concerns, and we can highlight that to inpatient teams, surgical teams, that may then be able to intervene during their admission, do something differently. But it also is a chance to educate the patient on how to optimize their recovery post-operatively, certain things to think about, certain medications. For example, for our Whipples and total pancreatectomies, we're able to give some really good Creon advice and addressing that post-operative element and how we can optimize. So absolutely, the longer the better, but there's still lots that we can do, even if time frame is quite short.
So Leah, how did you go about convincing people to pay for a prehabilitation nutrition service, which is the thorny issue forever in every health system?
Our funding initially came from our local Cancer Alliance. We then set about obviously setting up our service and collecting as much data as possible, doing as many outcome measures as possible to really pull it together before then presenting that to the trust. And it was actually presented as part of a wider cancer strategy. We just see cancer patients as part of our service. The things that we really addressed for our service was looking at the need for nutrition services in general. So we used evidence and data from Macmillan Holistic Needs Assessments to identify the severity of need as to what patients feel they want, and that was dietetic services, physiotherapy services to refer into, and then also using then the data that we had once our service was up and running. So looking at readmission rates, looking where we can at post-op or intraoperative complication rates, and then also getting that really positive patient feedback. I think as Elizabeth mentioned in her talk as well, I think that's so powerful. For example, some of the feedback that we've had is that patients don't feel like they're on their own. They feel that they have that support network around them. That all then plays into this element of empowerment and optimizing confidence, so patients can be autonomous in optimizing their recovery.
It sounds like we have to gather the baseline data, so identify the problem, measure what you're doing. So there's got to be a data collection component to this, and I'm quite interested in exploring that a little bit more as we go through our talk. Then presenting that and patient experience to people who may be paying, at least in the NHS land. Great. Okay, well, let's get our last panelist to join us. Definitely not least, Oonagh Griffin, who is a senior pancreatic cancer dietitian in the true nature of this Ireland USA EBPOM collaboration mishmash, is in Ireland. So St. Vincent's University Hospital, Dublin. So welcome, Oonagh. Lovely to have you here. I understand you mainly focus around pancreatic disease. Do you want to expand on what your role is and how you act in the perioperative space?
Great, thanks, John. So I suppose my background is I'm an oncology dietitian for about 20 years now. It's a struggle to get used to saying that, but when pancreatic cancer surgery was centralised to St. Vincent's 10 years ago, we were very fortunate to get dietetic resourcing as part of that. And I was probably about 6 months in post before I realised that I needed to be in pre-assessment. So I have been, seeing patients in the pre-operative clinic and the surgical clinic for about 10 years now. I'd love to think that I was thinking about optimization. I wasn't, being honest. It's usually I see somebody and they're probably, the target from MDT and meeting the patient is 10 days to them being operated on. So it doesn't give a huge amount of time for optimization. But one of the things I think it's important not to lose sight of is when you're talking about a surgery where there's going to be significant long-term digestive implications, actually what we can do from a nutritional perspective, it's that counselling element as well. And that was one of my main motivations for trying to see people in that space. Instead of me coming along and meeting somebody day one post a Whipple with an NG in their nose, draining, they're feeling sick, they're in pain, and I'm asking them what they usually like for breakfast, etc., what their dietary preferences are. So meeting them beforehand, and I suppose for me as well, because I'm cancer resourced as opposed to procedure resourced, the hope would be that I would be following these patients as long as they're going to be with us. So during the course of their adjuvant therapy, survivorship, etc. So I want the start of that therapeutic relationship to be a good one. So meeting me in a clinic situation as opposed to day one after their surgery.
Yeah, and I guess that's an interesting theme that's come up from everyone who's spoken today, is this number one, the education component for patients, and specifically, in some surgeries like pancreatic surgeries, but also these upper GI surgeries, etc., where there is likely to be a significant change in need post-operatively, this idea that pre-operative education and then connection with the post-operative team who will be continuing to follow seems central. We have some questions on Slido. So Vicki, over to you.
First question is by Mark Koch, and he wants to know, has anyone studied longitudinal outcomes, 180, 365 or greater days out to see if improved outcomes for nutritional interventions, if there were improved outcomes versus none in that longitudinal time frame?
Rebecca first and then move around.
We have not had data collection yet. We are in the process of studying our colorectal group, and we are doing immunonutrition prior to surgery and after surgery in this population and studying those outcomes. So we just started another year. So we've had a year of data collection and we're on to year 2. So looking forward to presenting that maybe next year.
Oonagh, you're in a very specific situation, aren't you, with your patients? Nutrition is central to outcomes, particularly with pancreatic. What about you from the point of view of long-term outcomes, in terms of your interventions? Are you measuring those? How are you collecting them?
There's probably 2 elements to that. I think there has been data that highlights the prognostic significance of malnutrition. And certainly we produced from Vincent's, we produced data on that at EAHBBA last week that showed actually baseline muscle indices does influence not just the post-operative morbidity and mortality, but also their 5-year outcome. In terms of our own work, we focused on patients receiving neoadjuvant chemotherapy. And that was, I suppose, in some ways, it was slightly more of an easy way out in that I could deliver a nutritional intervention concurrently to their chemotherapy. It gave us that discrete window of intervention without delaying surgery, because that's a very hard sell if you've somebody with a resectable pancreatic tumour to justify delaying when you don't know what your success will be. We have just done a feasibility study on that. It was one of the studies for my PhD, and actually we showed that a multimodal intervention was acceptable to patients, but actually the findings were so promising that we've just secured funding to take that to a randomized control trial. And in terms of, I suppose, coming back to, is the data there for upfront surgery? I don't think it's there yet in pancreatic per se, because I think the barrier is that time element. But I think the important thing to remember is often we identify it and we put that intervention in the pre-op phase, is that actually if we've identified them as being malnourished, we need to not neglect, nutrition support as part of their perioperative phase and their long-term phase.
I think that's a really interesting point, particularly about the neoadjuvant chemo. That's often an approach that other perioperative pathways take, because this is a window during which patients also suffer decrements in health as well. So support during that time has an added sort of secondary aim, really. And Leah, with regards to outcomes and supporting longer-term outcomes with nutritional prehab. Leah, I might ask you that in a bit. Sorry about that. It's for some reason the sound's not coming through there. Vicki, more Slido questions.
Oh my gosh. So in terms of optimization, what nutritional markers do you evaluate before and after the intervention?
Yeah, this is a thoroughly big question, isn't it? So what nutritional markers do we evaluate before and after the intervention? So we heard about some basic triage scoring, didn't we? We've heard about PONS and MST and MUST and all sorts of other things, but there's more to it than that, isn't there? Leah, are you back with us?
Can you hear me now?
Yes, we can hear you. Great. So I'll ask you that question instead. So
we actually use the PGSGA short form. So the patient-generated subjective global assessment scored just the short form. The reason for that, rather than the whole form, is our entire service due to COVID is still fully virtual. So unfortunately, we're not able to assess anthropometry with regards to physical assessment as we'd like to. However, from experience, I do find that the short form does give us some really good data. The key reason for choosing that assessment form for me really is assessment of symptoms that are affecting currently or potentially could affect nutritional intake. And I think it's really interesting. We've done a little bit of work, but it's not quite at the point where we can analyse the data fully, but comparing MUS scores with PGSGA short form, obviously where that is assessing symptoms affecting oral intake, but then also thinking about the exercise element as well. So obviously as part of that form, the key parameters we're assessing are weight BMI, percentage weight loss, current oral intake compared to normal, symptoms affecting oral intake, and then exercise or mobility compared to baseline. We complete that during that first appointment when the patient is referred to us, and we then look to repeat that at 7 to 10 days post-discharge, and it gives us a really good flavour of actually comparing the two scores and looking at the impact that actually the surgery itself obviously is then having on those nutritional parameters. We have started to introduce some biochemical parameters as well, particularly for our HPB population. So looking at trace elements, fat-soluble vitamins, and looking at that more robust nutritional screen and how we can correct any deficiencies in that pre-operative stage, particularly then thinking as those patients are likely going on for adjuvant treatment, how important it is to pick up those deficiencies as early as possible.
And with regards to screenings, so we've talked a little bit about providers who are not dietitians necessarily identifying our malnourished patients and referring them on to different forms of clinic. There's all sorts of clinics, but I'm quite interested as well, Oonagh, to ask a little bit more, to expand a bit more on the use of anthropometrics and also these blood-based biomarkers of malnutrition. What's your take on that?
What we use in clinic versus what we're doing in research is probably slightly different. So in our clinic, we have a physiotherapist. So often the nutrition goals and the physio goals would overlap. So it may be about improving physical activity. It may be about a set target, whether it's, steps or time walking, etc. Generally, what we're aiming for is weight maintenance, similar to what Elizabeth alluded to in her presentation. We'd look at hand grip, and recently we've adopted the NFPE, or the Nutrition Focused Physical Examination that Elizabeth mentioned. I think Ireland's adopting the NCP model. In terms of research, what we're looking at, we've used CT body composition data, and that formed the basis of a lot of the work I did. Now, it definitely, I think the advent of CT as a method for body composition got a lot of people interested in nutritional status in surgery, and I think it did us a massive favour. But I think we also need to recognise that it's a good way of assessing muscle mass, but not per se function. And we need to not forget about assessments that can be done really quickly in the clinic. So hand grip, timed up and go, sit to stand, and that's what we would use both for our pre-op patients and for our pre-chemo patients as well. And that's where we're looking for functional improvement. And one of the things I've learned from doing the study is that the patients absolutely love hand grip. So particularly those in chemotherapy where weight may fluctuate, it's tied to their dose, etc. They love hand grip. It gives them something else to aim towards. And I suppose what we're aiming for is preservation of function, preservation of quality of life. And that's really what, they see that as a better marker for them compared to weight. So in terms of biomarkers, similar to what Leah would say, any of our patients, particularly those who've maybe had prolonged biliary obstruction, they might have needed a couple of goes in terms of stenting. If they've had an external drain, we'd certainly be trying to measure fat-soluble vitamins and get on top of any deficiencies as soon as possible. But for any of our patients with exocrine insufficiency, we would at least once a year. So these are the long-term kind of follow-up. They'd come in for their regular NCT, MOT, and assessment of micronutrients as part of that. The other thing that we would check as well is glycemic control. And we have certainly found there is a massive under-recognition of undiagnosed diabetes in our cohort. And actually it comes back to what Elizabeth was saying in terms of HbA1cs and wanting those to be in target ranges before patients proceed to surgery. And often that can be the first thing I'm doing in clinic, is actually getting endocrinology involved and getting somebody started on insulin to take their sugar down from 20 or 30 to a more normal range.
Rebecca, again, you've got multiple pathways with multiple different risk scores. Do you have multiple different biomarkers and physical assessments as well? Or how does that work?
We do. We do. I would say for the most part, our dietitians are all doing a nutrition-focused physical exam when we get a consult. So that is number one on muscle wasting, fat wasting, and palpitating those areas for assessment before and after, and looking at that. In certain clinics, we do use the grip strength. So very similar to what Oonagh was saying around grip strength. We have found that very helpful, but also sit to stand, the walking, all those time measurements of physical function are utilized in certain areas of clinic. We also measure vitamin D in certain areas, as well as the A1C in terms of those glycemic markers. You know, BMI is used occasionally. It's definitely something we look at, we measure, and we follow, but we know that in these pre-op spaces, BMI is an indicator of their intake. And so really, you know, I think one thing that the dietitian is really specialized in is determining how much is actually being able to be taken in by the patient. So we're really doing an assessment of their protein intake in current state, pre-operatively and post-operatively, and is it meeting their nutrition needs?
Lovely. Oh, Vicki, I'm sure you've got many more Slido questions. Go for it.
I do. So we talked about, you know, the initial assessment and then follow-up and the measurements, and that was great. And somebody wanted to know, how do you do that evaluation? Is it telehealth? Is it face-to-face? Are there reimbursement opportunities here? Tell me a little bit about that.
Why don't we stick with Rebecca for now then? How are we doing that initial assessment? And how were you doing it, and how are you doing it?
Sure. So I would say once we're identified to see the patient, that initial assessment right now is usually done over the phone or a telehealth visit with the patient, so we can get to them the fastest, so they don't have to come in. Or it might be somebody that the physician's seeing in clinic, and it might be a dietitian that's in that clinic, and they might just knock on the door and say, hey, can you come see this patient? You know, they're screening positive for malnutrition, so they come grab us out of that clinic to talk to that patient in person. We have noticed that with some of, you know, the phone conversations, we don't get that clear indication of malnutrition that you would as a visual assessment. So it is a slight barrier to this new kind of world of making sure that there is a video option for the patient so that we can really see them and see what their body looks like, and making sure that they're not malnourished on the other side of the phone.
Oonagh, again, in person, in clinic, on the phone, how are you doing it?
Oh no, it's definitely in person, because I'm in the pancreatic cancer MDT. So when the surgeons are deciding about resectability with radiology, etc., I'm there, so I kind of know who to keep on my radar list. I'm in the individual surgical clinic, and, you know, depending on the situation, if the patient's just been informed of their diagnosis and not in a, you know, position to take part in a consultation, that's not always the best time. I would say for a lot of people it actually is, whether, you know, nutrition is one of the things that is distressing them and they're happy to address it there and then. And then we're very fortunate to have a second dietitian in pancreatic disease who covers the pre-op clinic. So she's there with the anaesthetist, I'm there with the surgeons. So if I've had a chance to get in on day one, she's catching up at day two and assessing and making sure that they're on the right path. Where it gets difficult is if we're meeting somebody and they're resected and they're, you know, within a week. So often that next visit will be day one, day two post-surgery. But I think where we see the improvements there is, instead of somebody not appreciating the fact that they need to take pancreatic enzymes with their meals and having to start that education piece. They're asking for them day 3, day 4 when they're back on diet. So they're informed, they're empowered. And I think we need to think about that in terms of successful outcome measurements.
Leah, so I guess you've got a slightly wider population, quite high numbers. How are you dealing with seeing patients?
We are completely telehealth, more or less. Physio that I work alongside is now starting to do a lot more face-to-face, which she's very pleased about. I'm kind of itching to get back there myself. Due to the pandemic, our kind of planned service kind of got turned on its head slightly. A bit like what Rebecca was saying, the original plan was actually to carry out the initial screening, which was due to be done by ourselves over the phone. And then essentially for those more targeted or specialist patients, we would then see them face to face in a one-stop shop that would encompass myself, physio, and bring in that psychological element as well. So unfortunately, we haven't been able to implement that one-stop shop element yet. But hopefully, all fingers crossed, that is the direction we're going in. I think the other challenge we had is that the service we run runs across 2 different sites, 2 major sites. But actually, there's just one of myself and one of the physios. So unfortunately, we're not able to be on site in dedicated clinics at all times. So it is thinking about how best to utilise our time. And so we actually do end up condensing our services to one prehab clinic that would cover all 3 of our pathways. As I say, I think it would be interesting to be able to analyse different outcomes once we are able to open up more face-to-face appointments, and see actually if there is a significant difference in outcome or how engaged the patient is or their kind of view of the quality of the service. I think that would be a really interesting piece of data to look at. From what we've collected so far, we feel that the service we're running is providing what we want to, but we can always do more. And I think actually having that comparison study would be great. But unfortunately, we're having just to go with what we can do at the moment, hopefully still providing, a good quality service where we can.
So Vicki, I think we've got enough time for another couple of questions, haven't we?
So this is a really good question. For those who are using the MUST tool, the Malnutrition Universal Screening Tool, and you have an obese patient, and they haven't experienced any weight loss, how do you really assess their nutritional status?
Rebecca, do you want to answer that one?
I was going to, because we don't utilize the MUST right now at Northwestern, but we do see this on the inpatient side quite a bit, as well as the outpatient side. We do assess mainly through intake. Intake, are they holding on to other areas of other signs of malnutrition in terms of muscle depletion? So that physical assessment, again, is very important of these patients, but as well as that intake and what compared to their estimated needs.
Do either of Oonagh or Leah want to talk about how you would assess malnutrition in an obese patient with MUST?
We use MUST across the board in the hospital, and I think we've added it into pre-op assessment purely because we can't have different tools in different areas. Often weight loss in an obese patient is misperceived as advantageous, so it may be missed. So certainly when I audited the first 150 patients that were referred to me initially, the average BMI was 27, but the average weight loss was 12%. So, and actually for a lot of those, MUST had picked them up because they didn't think weight loss mattered because they had it to lose. In terms of how we'd measure outcomes, we'd go more on function. So we'd look at nutritional intake, definitely. We'd consider nutrition impact symptoms. But what we're aiming for there is maintenance or improvements in grip strength, certain that they're making progress with the physiotherapist, that their activity is improving. And I guess that we'd also be looking at things like their blood sugars, if that's something that we should be looking at, their glycemic control and that. But I think it's difficult. And I think that's something that's not specific to MUST. I think it's down to the fact, certainly from a European perspective, 60% of adults are overweight or obese. So I think we need to think about, is weight or BMI the best way to be screening these patients, and maybe something more specific like a sarcopenia assessment tool or something might be more valid.
Vicki, it sounds like we've got probably enough time for a last question. What do you reckon?
Yeah, really. Last question here. It was for Leah and Rebecca, but I really think everybody could answer this. In addition to high proteins, do you all prescribe immunonutrition perioperatively at any point to your patients?
Rebecca?
Yes, so in our certain spaces, so I would say we just added it to our colorectal protocol as well as our cardiac ERAS protocol. Those both coming in different areas of the clinic. We're recommending the immunonutrition 7 days beforehand, 7 days after surgery at this point in those areas here.
And maybe Leah, just as a sort of last answer, immunonutrition?
So it's not actually something, it's not something that we regularly recommend. As you say, I think for us, the variability of time to surgery probably be a factor, but I think absolutely a very interesting, piece of work, a piece of evidence, and I'm interested to see the outcomes of that, and maybe it's something that we do look to consider in the future. Well,
Vicki, I don't know what you think. I mean, that was I've got so many more questions to ask, but we've run out of time. An interesting area, and this is definitely a growth area, I think, in the perioperative space. So hopefully we can talk more in future meetings.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.